Our next speaker is Dr. Shah. Dr. has special interest in cross-sectional imaging and non-vascular interventions. He has expanded more than 5 Medimex imaging branches. He is a great cricket enthusiast also. I would like to invite him on the dais.
Good morning everyone, thank you for having me here. So today we'll be discussing the imaging techniques in frozen shoulder. Mainly just going ahead, I would like to tell you that it's mainly a clinical diagnosis, and obviously to stamp it, imaging is very sensitive and specific, especially the MRI. So quickly moving forward. What is frozen shoulder? So it is a condition characterized by thickening and contraction of the shoulder joint, capsule and the surrounding synovium, and then there is buildup of the scar tissue which restricts the movement of the joint and resulting in pain and limiting the motion. It's more commonly found in female population. 5th to 6th decade is the more common age group which is affected, and comorbidities such as diabetes mellitus and hyperthyroidism. In such cases, the presentation can be also early. So mainly there is pain and restricted motion, especially the external rotation is affected in these patients. Quickly going, there are 3 stages clinically. The first one is the freezing stage, where the pain is the predominant feature and motion slowly picks up in getting affected. Then there is the frozen stage, where there is fibroblastic activity, the pain reduces and the range of motion decreases further. And then there is the thawing stage, which lasts up to 3 to 4 years in many patients, and it is gradually there is return of the motion. So what are the imaging modalities used for frozen shoulder? MRI and MR arthrogram. So MRI is the gold standard. USG can be useful to diagnose and correlate clinically. Plain radiography and CT scan are not useful for diagnosis or staging of frozen shoulder. And conventional arthrogram, which was done previously before the MRI and USG, but that is all historical and obsolete now. So before going further, let us quickly just see a few imaging spaces which we have to visualize both on MRI and USG in frozen shoulder. So the rotator cuff interval, that is the main region where the fibroblastic activity scarring happens. So these are the 2 images of a normal MRI. This is a T2 weighted sagittal image and this is a T1 weighted image. So this is the rotator cuff interval. It is bounded anteriorly by the coracoid process, superiorly by the supraspinatus and inferiorly by the subscapularis. So here is this rotator cuff interval, where normally you will find nice fat. You won't find any soft tissue here. You will see fat. Then there will be visualizing this ligament, that is the coracohumeral ligament. And then here with the short arrow, what you see here is the long head of biceps tendon. So these are the 3-4 structures which are nicely going through the rotator cuff space, and there is no soft tissue or scarring here. Similarly, here on the coronal image, you can see the coracohumeral ligament. Another space which I would like to tell you is that the axillary pouch, or which is made by the inferior glenohumeral ligament. This is a T2 arthrogram. You can see nicely distended axillary pouch here. So there is no thickening. It is less than 3 mm the inferior glenohumeral ligament, and if arthrogram is done, it is nicely distended. So this is how it would look, a normal axillary pouch. So on MRI, what all things will we see? So in these 2 spaces, whenever you see any abnormal soft tissue thickening or any abnormal signals in the rotator cuff interval or around the biceps anchor, then you should raise a doubt if there is a clinical suspicion. Then there is a subcoracoid triangle sign. So whenever the fat which I told you in the rotator cuff space interval, if that is not clear, or it is hazy, or there is soft tissue, then that sign is positive. So that is very sensitive and specific. Direct visualization of the coracohumeral ligament, if it is thickened more than 3 mm, we consider it to be positive. Also, as I told you, in the axillary pouch, if there is joint capsule thickening more than 3 mm or any hyperintense tissue or signals, then you should raise a doubt. And in case you happen to do post-contrast MRI or contrast MRI, then you will see the scarring tissue to enhance. Generally, we don't do it, but if you do, then you will see enhancement because of the fibroblastic activity and the scarring. So here is an image. This is a 𝙃𝙬𝙧 sagittal image, and as you can see, there is thickening of this ligament, that is the coracohumeral ligament. If you can see the fat which is supposed to be hyper intense over here, that is all looking very dirty. Even surrounding the biceps anchor, there is dirty looking tissue. So this is a thickened coracohumeral ligament, which is very sensitive for adhesive capsulitis. Another is the subcoracoid triangle sign. As I told you, beneath the coracohumeral ligament and between the coracoid process and the tendons, there will be a nice fatty tissue which will be seen. In case if you don't see this fat, and if it is obliterated due to any scarring or soft tissue, then it is a positive subcoracoid triangle sign, and this is very specific for the diagnosis of adhesive capsulitis of frozen shoulder. Another, this is a normally distended nice axillary pouch. You can see thin inferior glenohumeral ligaments. If you see thickening of this glenohumeral ligament, or if the patient has joint diffusion, or you have performed the arthrogram, and if you see it is not getting distended, then again it is quite sensitive and specific for adhesive capsulitis. Again, this is axial images taken at the level of the inferior glenohumeral ligament or the axillary pouch, and you can see that there is soft tissue and hyperintensity. So these are again diagnostically helpful for adhesive capsulitis. If you happen to do an arthrogram, because the space it cannot distend, so there will be a leakage of contrast outside the joint space, as seen in these two cases. So this is on MR arthrogram. This is what you will see. Before, when there was no MRI, people used to do conventional arthrogram, which is not performed, but you can see here in a patient with adhesive capsulitis, the inferior, this axillary pouch, it is not getting distended by the arthrogram. And so what is happening, even this space, which is supposed to be the rotator cuff interval, it is also not getting filled. So probably there is scarring over here, and the contrast which is given is getting leaked outside the joint space. So same like MR arthrogram, this is conventional arthrogram on X-ray, not done now, not needed, because we have MRIs. USG, the same things. You can see a thickened coracohumeral ligament. You can see thickening of the axillary pouch. Another sensitive sign on USG is that in the rotator cuff interval, if you see anything surrounding the biceps tendon which is looking dirty, and if you put a power Doppler, if you see some vascularity because of increased vascularity which is supplying that scar tissue, then it should always raise a doubt of adhesive capsulitis. And if you happen to see in dynamic USG scanning, if the supraspinatus is not moving smoothly, then again that is a sign of adhesive capsulitis. So this is a case where they have demonstrated thickening of the coracohumeral ligament. Another case, they have scanned this USG is at the level of the axillary pouch. This is the inferior glenohumeral ligament. So this is the left side is the abnormal one, and this is the normal one. So you can see here on the normal side it is not thickened. Here it is thickened. If you so this is another image where this is the long head of biceps tendon. Surrounding it there is dirty looking echoes, and if they have kept a power Doppler which is showing increased vascularity. So this is useful in diagnosing. So what are the key points? Mainly the first it is a clinical diagnosis. Imaging can be used to exclude other articular and rotator cuff pathologies, and most common findings which we see are thickening of coracohumeral ligament and the inferior glenohumeral ligaments, and also the rotator interval fat pad obliteration in MRI or in USG, as I told you, surrounding the biceps tendon. If you see the fat is not looking good, so that's a very specific sign. And ultrasound, obviously, in non-vascular interventions for injecting steroids or any hydrolysis, it can be used. Thank you.